Hello, everyone. It's 2 p.m. Eastern Time on Wednesday, May 19th. Thank you very much for joining us on the Alliance to Fight for Healthcare briefing, Beyond Health, the Value of Employer-Provided Healthcare Coverage. If you have a question or comment at any time, you can type it into the Q&A box in the bottom right corner of your screen. For best results, please make sure you are sending your question to all panelists. We will take questions throughout the webinar and pause periodically to pose them to our speakers. Please note today's event is being recorded. To get things started today, I am pleased to present American Benefits Council President James Klein.
Thank you, Jason, and welcome everyone. We really appreciate you joining us today for what I know is going to be a really interesting presentation and conversation around these issues. Just a bit of a background on the Alliance to Fight for Healthcare for those of you who may not be familiar with the coalition. Its origins really were back in 2015 as a diverse group of stakeholders, public and private employers, unions, patient advocacy groups, nonprofits, and others got together over their common interest and support of employer-sponsored healthcare coverage and their concern about the impact on employer-sponsored coverage of the 40% so-called Cadillac tax that was incorporated within the Affordable Care Act. And although the groups have had a diversity of viewpoints about the ACA overall, they all agreed that that provision needed to be repealed for the sake of the billions and millions of people who are covered by employer-sponsored health coverage. So long story short, that group worked very diligently along with others. And as you undoubtedly know, the Cadillac tax was repealed in December of 2019. As the coalition was sort of beginning to work together on other initiatives, lo and behold, the pandemic struck. And so we very quickly pivoted to what we might be able to do as a coalition to address those needs. And among other elements was the call for subsidized COBRA to keep people on their employer-sponsored health coverage. And as you may know, that was about a year battle as well, but ultimately temporary subsidization, full subsidization of COBRA through the end of this fiscal year was incorporated in the American Rescue Plan. All three branches of government are focused on health right now. The regulatory agencies under President Biden are reviewing a number of the Trump administration policies. Part of the president's governing theme of building back better specifically is embedded in his family infrastructure initiative in terms of the elements that would deal with health benefits. And of course, the Supreme Court will hear from any day now, certainly by the end of next month, in terms of its ruling on the constitutionality of the Affordable Care Act. Employer-sponsored coverage by far is the largest source of coverage for Americans. About 160 million Americans, roughly half of the nation's population, get their coverage through their own plan or a spouse's plan or parent's plan. I think we all would acknowledge that the pandemic has caused policymakers, the media, and all of us as the public at large to re-examine countless things about our society and our lives, social justice and racism, how we travel and how we purchase things, how we interact with family, friends, professional colleagues, where and how we perform our work. And the topic of healthcare has obviously been squarely in focus as well, and not just addressing the treatment of COVID-19 or obtaining the vaccines, but also issues like access to behavioral health resources, growth of telehealth and how we interact with our healthcare providers, ensuring flexibility in how we spend our healthcare dollars as certain planned procedures that we may have thought about at the beginning of, say, 2020 were delayed until the pandemic was in the rearview mirror. And therefore, the value of employer-sponsored healthcare coverage through which most of us as Americans and perhaps everyone or almost everyone on today's webinar obtains their coverage, it has also been scrutinized as well. And so fortunately, we have two experts with us today to shed light on this last point, the value of the coverage that we all need and use. Tracy Watts is Senior Partner and the U.S. Leader for Healthcare Policy at Mercer, the global HR consulting firm. Proud to say she's also an officer on the Board of Directors of the American Benefits Council. Tracy will share with us some of the latest trends from Mercer's global survey of employers and comment on some of the innovative ways employers have been able to respond to the needs of their workforces during the pandemic. We also are delighted to be sharing with you some really fascinating research that was recently published by the National Bureau of Economic Research. Dr. Casey Mulligan is with us. He is a professor of economics at the University of Chicago. His research includes health economics, the taxation of labor and capital, gender wage gap issues, and others. And he's going to share some of the findings of his recent research on employer-sponsored health coverage and aspects of it that I think that have gotten relatively little attention in the past, which I think is what's going to make this so intriguing. He's going to talk about the social as well as the economic benefits of health coverage, the perceived value of it by those of us who are fortunate to have it, the impact of employer-sponsored coverage on innovation, productivity, and of course, health itself. So please send us your questions, as Jason was indicating. And thank you, Tracy and Casey, for being with us. Let's turn it first to you, Tracy Watts. And I don't know whether you're muted, perhaps.
Thank you, Jim. I am thrilled to be here, and hello, everyone. Let's go ahead and go to my first slide. Before I jump into some of our data, I just want to acknowledge that with regard to healthcare, the affordability issue is real. And it's not just for plan members and their families, but it's real for employers as well. And I just feel like it's really important for us to acknowledge that up front. Because I do think that that is the issue that truly drives the public debate on this topic. Over the next couple of minutes, I'm just going to share some survey data from Mercer. We do a number of surveys, and so for the most part, I'm going to focus on our annual survey of employer-sponsored health benefits. And it is the longest running survey of its type. We just hit our year 36. It's very robust. I think that's important for you to know. We have almost 2,000 employers that participate in it. The results are statistically valid and projectable. And so, you know, this isn't just a convenient sample of about 100 employers, it's almost 2,000. It does include employers of all sizes. So it's not just the jumbos, it's going down to employers with 50 or more employees. So let's go to the next slide. Let's jump into a couple of the findings that I want to share with you today. And let me set up this slide because it's going to be a bit of a build. I'm going to share with you 3 cuts of our data. So you'll see the first bar are what we call smaller employers with 50 to 499 employees. The mid-size employers, 500 to just below 5,000, and then 5,000 or more. So as we think about the year that we've been through, the pandemic, you know, there was a slowdown in cost growth for employers because people stayed home, they stayed put, they didn't want to go to the doctor's office or the hospital. And despite that and some economic uncertainty, very few employers made changes to shift cost. And those are the bars that you see on the screen right now. So for small employers, only 12% made changes that would shift cost, 20% of the medium, 15% of the large. If we go to the next slide, we'll layer in one more thing. We actually saw employers change their plan design to make healthcare more affordable. Let me just say that one more time, to make healthcare more affordable. And that is the bar that you see now that's been added to the screen. Not a lot, but this never happens. And so it is remarkable from that perspective. Then let's go to the next slide. We'll add one more factor into this. These are the percentage of employers that actually expanded resources to provide additional support for employees. And you'll see in the jumbo employers, 68% of them, that's, you know, just about everybody, added benefits, 53% in the mid-size, and 35% in the smaller. And I just think that that really shows a responsiveness of employer-sponsored programs to employees and their needs. So, so that's the first thing I wanted to share with you. Typically, that begs the question, you know, what did they do to expand benefits? So on the next slide, we've got 4 areas where they did that. No surprise, the first one was to expand or incentivize telemedicine, virtual care. I don't know if you remember, but back in February and March, when people first started thinking that maybe they had the virus, they were told, please don't go to the emergency room. And in fact, don't go to your doctor's office. And fortunately, at that time, over 90% of employers had a telemedicine program embedded into their health benefits. And so they were able to direct people to telemedicine for triage. Those benefits also got expanded to cover more things during the pandemic because that became a really efficient way to at least get some type of initial triage and direction to care. The behavioral health issue had a very big light shined on it during the pandemic, and a lot of expansion of behavioral health benefits was done, particularly virtual behavioral health benefits. We saw more interest in voluntary benefits and other types of targeted point solutions. So a lot of activity going on to bring programs to employees.
Hey, Tracy,
yeah.
could I just interject here? Could you give maybe an example or two of what you mean by these point solutions?
Sure. So the most typical point solutions, I mean, telemedicine actually in the early days was a point solution. It's something that the employer adds in, layers on to their benefits program to address specific needs. We see them very commonly to support plan members with diabetes. That is a chronic condition that is probably the most well documented in peer-reviewed journals for having the best return on investment. And so solutions for people with diabetes, other chronic conditions, things that are an advocate for employees that are going through specific issues and they need that extra help. We see point solutions to support parents that have children with autism. There's just a myriad of solutions out there.
Thank you. Thank you.
Sure. Let's go to the next page. There's another finding that I want to share with you that I think is particularly interesting for the topic today, and this is around full replacement high deductible health plans. When these programs were first implemented, many employers planned to be on a glide path where high deductible health plans would be the only types of plans that they would offer. And we actually have seen a pivot on that, or a reversal of that strategy. And in this graph, you can see for mid-sized employers in 2018, about 13% had gone full replacement, or they thought that they were going to be going there, which is the bar below. And in 2020, that actually declined to 10%. In the jumbo market, the decline on that was even more pronounced, from 22% to 15%. And so why is this? Why did they do this? Well, they did it because they began to understand that not everybody is comfortable in a high deductible health plan. People have different needs and different priorities, and the choice became very important to people. And that was something that employers realized as they got more into this. I will say, and I don't know if this is, go to the next slide. Let me see if it's on here, that in spite of that, we have seen growth in the enrollment in consumer-directed health plans, namely those who are eligible for health savings accounts. So you'll see just from like 2015 to 2020, we saw growth from 25% to 38%. So they are popular and they continue to grow in popularity, but we realize that they're not for everyone.
If I could just interrupt you once more. When I saw that prior slide about employers pulling back from full replacement, I would have expected that the next slide you were going to show was going to show the bars going in the other direction, that they were pulling back from it because people just weren't really that interested in it. But this one shows, I think this is sort of another representation. Tell me if you agree that this is the right takeaway. Your prior slides showed all these things that employers were doing to be flexible and, address employees' needs during the pandemic. And this kind of shows, likewise, even though as these plans, if I'm reading this right, are growing in popularity and greater percentages are enrolled, employers are also pulling away from full replacement because they recognize that people like to have a choice. Is that what your message would be? Did I get that right?
Yeah, and I think actually my message throughout all of these slides is really to show just how nimble employers are. I think examples of that are much faster adoption of telemedicine. It took the CARES Act to get telemedicine for Medicare. Employers have had it in place for a number of years now. Just the ability to very quickly pivot and increase support for mental health. And, when they saw that that the high deductible health plans didn't work for everybody, they're like, okay, well, let's keep these other options open. And so I think it's a very responsive program to the needs of the plan members.
Got it. Thanks.
Sure.
Tracy,
sure.
before you move on to your next section here, we do have a couple of questions in the queue. And one of them sort of dates back to one of the very first things that you mentioned, which is about the employers seeing some cost reductions because people were delaying and deferring care. And one of the questions we have is, are employers going to, or have they started already, passing on those savings from 2020 to employees?
So as you can see in the data, fewer raised the premium share or increased deductibles. Like definitely we saw them pass that on to plan members for 2021. For 2022, I think that, that's still being reviewed. This is the time of the year when all employers are exploring what their strategy will be. And, we are expecting to see a bit of an uptick in medical expenses, plan expenses in the second half of the year. Whether it will be like this full bounce back, personally, I do not think so. If you look back to patterns that we saw with the recession in 2008, we did not see a huge increase, a big bounce back from that. I realize it's not the exact same circumstances, but we don't have a lot of things to compare this to. What I will say is that there are more and more ways that employers have to manage their programs and still be very responsive. And I think that there's a lot of focus on what those strategies are so that they can avoid cost shifting where at all possible by really focusing more on where's the value.
Jason, if you wouldn't mind my commenting on that one as well, I would just say we did some surveying of our own employer-sponsored members, as you know, Jason, and while they were reporting across the board lower costs in 2020, they all were anticipating higher costs this year and 2022 and beyond, in part because of the pent-up demand from all of those discretionary procedures that weren't performed last year, but also, sadly, because people weren't necessarily going and getting all of the same kind of regular services and visiting the doctor, that certain conditions would be identified later on than they otherwise would have been. And so that kind of also speaks to this issue about the anticipated increase in costs. Go ahead, Tracy.
Do you have any more? Do you want me to go on to the next slide?
For now, let's keep going.
Okay, so I just have two more slides. I just want to comment briefly from a public policy perspective. And so let me just set up this slide. We did a survey right after the election. And so this is not from our big employer-sponsored survey. This is what we call a 10-minute survey. And I'm just sharing it with you because the two biggest drivers of cost in the employer-sponsored insurance world are pharmacy benefits and high cost claimants. And they happen to a lot of times be one and the same. And so we gave employers a variety of policy issues to choose from. And the number one thing on their list that they were interested in being included in public policy going forward had to do with some type of management around the cost for prescription drugs. And that's what's on this slide here. I'm not going to go through every little thing that we asked them about, but I just think the fact that 77% were favorable around cost controls for prescription drugs says volumes. And it is something that, you know, employers are very interested in seeing how this plays out from a public policy perspective. I realized that the ability for Medicare to negotiate Part D was not included in this most recent plan that the president rolled out, but you know, it is something that is still being talked about a lot. It's, I think, got $500 billion in savings connected to it, as well as savings for the commercial market. So it's just a very big issue that employers are focused on. If you go to the next slide, this is some brand new data from our from a global survey that we do. So again, yet another survey. So let me set this up. A couple of years ago, we started a new survey. It's called Health on Demand. We run it globally. And the results that you see here on the screen are from surveys of citizens in countries around the globe. For the U.S., 2,000 people that have health coverage were interviewed, surveyed for this particular study. And what you see on this graphic are what percentage of the people that responded have medical coverage through their employer. Okay, so I want to make a statement here in that you see all of the countries listed on here besides the U.S. and Canada. We got Brazil, Mexico, France, the UK, China, Singapore, okay, all around the globe. And those green bars are pretty hefty across the entire slide. And the reason why I wanted to share this with you is that everyone thinks that, you know, all these other countries have single payer systems. And in fact, there's really no such thing as a single payer system. Probably the UK would come the closest to that, but you can see half of the people rely on access to some level of benefits through their employer. The second bar that I want to point out is access to mental health counseling services, where the U.S. has the biggest bar there at 67%. And I do think that particularly during the pandemic, this is a place where we have seen the U.S. really rise to the occasion in terms of what they're doing to support people. So the last thing I want to share with you that's from this study, I don't have a slide with it, but we asked all of these citizens to rate who they trusted most to deliver health to them. And so, no surprise, I'm just going to share the results from the US. No surprise, a healthcare professional, their doctor was number one on the list. In the US, my employer was number two on the list, with 74% being favorable about the support that they get from their employer for their health care. Number three on the list was not the government. It was actually online retailers like Amazon. So I just want you to think about that and carry that around with you for a little while. And then that was at 66%. And then following behind retailers was the government at 61%. And so I just share that with you, you know, to think about our system and in particular, employer-sponsored insurance, all it does to support basically, you know, over half of the American people, and just how nimble it has been during, you know, truly a time of crisis for our country and for many people. And so with that, I'm happy to have my co-panelist present the amazing work that he did with his most recent paper. Or back to you, Jim, either way.
Before we move on, I do want to slip in one more question from the audience here for Tracy. Tracy, you talked a little bit about high deductible health plans, but do you think that employee enrollment increases into consumer-directed health plans? Do you think that that's driven by millennials who have lower overall healthcare needs?
I think everybody makes a decision based on their own financial situation. And I think the two biggest things that people look at are the deductible and how much is going to come out of their paycheck. And we've really found of recent that the amount that comes out of your paycheck is keenly important. As everyone knows, wages have barely been going up each year, just a couple of percentage points. And so that need to have as much money in your paycheck as you can, I think, perhaps has driven people to lower cost options. But with that said, the reason why employers are moving off of that full replacement strategy is because there are people that have value for, the higher cost plans that give them lower out-of-pocket expense. And so I don't know that it's really attributable to a certain generation. I think it's more, driven by one's own financial situation.
Take it away.
Well, that was interesting. I love all that data that Tracy has. Good afternoon to everybody. I got started on this, there's so much data available in academic studies on health insurance. And I thought it was a good time to gather it together and address a new and interesting question. Namely, the question is, what is the value of employer-sponsored coverage? We know what it costs, and that's a legitimate measure of value. But I wanted to know what kind of benefit consumers receive. In technical terms, the question is, what is the surplus? So if we could advance to next slide. So when I said value to the consumer and to our country, thinking of two components: private value and external value. And the private value accrues to the parties of the transaction, the employees and their families that are, actually signed into the plan. But the externality value accrues to third parties, especially the effect of that kind of coverage on government revenues and expenditures. And one of the methods used in the study is the revealed preference method. And that method's about the willingness of consumers to pay with their own money. According to this method, a product is valuable, at least from the private perspective, only if it passes the market tests. People go out there and buy it. The demand for employer-sponsored coverage is strong, and it's been proven strong over many, many years. Even in instances when it becomes more expensive, or in instances when the alternatives become cheaper. And that's very important observation, how employer coverage continues to overwhelmingly pass the market tests. And I think Tracy had showed us some of the reasons in the very recent history why it is passing that market test and why people will stick with it if it gets more expensive, or even if alternatives get cheaper. Let's look at the next slide, please. So here are some of the numerical findings for the various components of value. The numbers here are in trillions with a T, not with a B or an M, but a T. It's so valuable we measure things in trillions on an annual basis. Now, all three of the components, remember the first component is the private value, second component of value through tax revenues, and the third value through government expenditures. All three of these are significant. They're not identical, but they're getting into the hundreds of billions each by themselves annually. And the grand total here is about 1.5 or 1.6 trillion surplus. That is, benefits beyond what the product costs. Now, if you want to, trillion is for our whole country. If you want to think on a per person insured, per person signed into a plan, that's about $10,000 on average for each of those persons annually. So that's a lot of value.
Hey, Casey,
yes.
What is the increased taxable factor supplies? What does that refer to?
Yeah, there's two parts of tax revenue that are especially important. One gets a lot of attention, which is there's a tax favor or a tax preference for employer-sponsored insurance, and that reduces tax revenue, and that's all by itself, and that's not good for the Treasury. But there's another effect, which is employer-sponsored coverage. Sounds obvious once you say it. It's attached to work. It's something you have to be involved with work or have a family member involved with work to get these benefits that we've talked about and that Tracy talked about. And work is something that has external value. In fact, 80% of our tax revenues are generated by people working. And so something that encourages work can actually increase tax revenues, and employer-sponsored coverage is one of those things.
Got it. Thank you for explaining that. And so the compelling number here, I guess, is, $10,000 per year per insured life. I mean, as a social value, that's pretty substantial.
Yeah, and that's a surplus. I mean, of course, this is not a free product,
right?
But this is over and on top of that. Yes.
Right. Even more compelling. Right.
And that's why people stick with it. Sometimes it gets more expensive, or in some circumstances, in some states, in some family situations, it gets more expensive. Generally they stick with it, or the alternatives get cheaper, which is something we've seen this year. ACA plans for many people are actually free, but I don't think we're seeing a lot of people switch because they like that employer coverage, and even when the alternatives get cheaper, they stick with it because they stick with something they like, and they're not really gravitating to alternatives that they don't like.
Thank you.
Yeah, we can go to the next slide. So, I talked about an average of 10,000 per year. As a proportion of compensation, this is incredibly big part of the compensation for your middle and lower income people. $10,000 worth of, that number might not be identical for everybody, but all those people care about their health, and they all value the financial security that involves when they go into a period of sickness. And so as a percentage of compensation, that's a really big deal for lower income and middle income people. Somebody who's earning $500,000 a year, maybe they would be willing to self-insure, or being self-insured wouldn't be such a harm. But for somebody of middle or low income, self-insurance or some of these other alternative products would be a big step down for them as a share of their compensation. We want to go to the next slide. This is the majority of people in the United States are covered in this way. So there's no other way that people are getting coverage that's as big a deal. And that's one of the things that it's both reflecting the value that people really appreciate this product and pay for it with their own money, but also from a fiscal perspective, from the government perspective. If you didn't have this kind of coverage, what would be the alternative? Those alternatives could be pretty expensive from a government perspective. Let's look at the next slide. One of the features of employer coverage is it's in a group, and it's a group, the group being your fellow employees. It's a group that's formed for really other reasons other than healthcare, and that's actually a very effective thing from a competition perspective, also from a risk management perspective. When you're issuing coverages to a group like that, you don't have to worry so much that the people are very specific in their health needs. There's a variety of people who work for any company. And from the competitive standpoint, this can help get some pretty big discounts. We have to recognize that the healthcare landscape now, on the provider end of things, things are often not very competitive there. And the consumer could get pretty steeply overcharged. But these group purchasing arrangements can be very helpful. I like the analogy with Costco. Where a lot of us go to Costco, or some I like going to Sam's Club myself. But these are buyers clubs that really help consumers get a big discount, because they tell the manufacturer or whoever's providing the good. They say, hey, if you don't give us a good deal, you're not getting any of the people who come into Costco, or you're not getting any of the people who come into Sam's Club, and that gets their attention, and they drop their price pretty significantly. And we see those kind of discounts, and I quantify those in the study, very significant discounts that employer plans are able to get because of these groups that they're putting together.
And you couple that with the point that Tracy, you were making around cost, and you see how substantially more difficult it would be were it not for that employer purchasing. And I think the point that you made, Casey, about how the significance of the people sort of banding together, perhaps for other reasons, but creating a risk pool that's more meaningful is just can't be overstated. And I think that's often overlooked.
Yeah, it's very much overlooked in the kind of commentary around it. I mean, it's not overlooked by the consumer. They very much appreciate paying less rather than more. It might be worth giving another example that we use when we look at buyers clubs. Is actually something we study here at the University of Chicago in general, not just for health insurance. An example we use is a restaurant, not necessarily a big restaurant, although there are big restaurants or small restaurants, but you go to a restaurant not for the soda that they have, right? You're going for the type of food, the atmosphere, the type of people you come with. Because they've assembled that group of consumers, diners together, they get a very good deal from soda companies, because they tell Coke, they say, hey, if you don't give our restaurant a good deal, no one in this restaurant is going to be drinking Coke. And they say the same thing to Pepsi. And as a result, they get some very steep discounts on soda. And that's the group purchasing arrangement. And Coke and Pepsi would love it if people just shopped individually for the soda, because then they could jack up the price when they detected, aha, here's a Coke lover or here's a Pepsi lover, and then jack up the price. So this is something I think very important, and I hope it gets more attention because it's delivering real results to our consumers.
I think another example is what we saw when the ACA was rolled out. And I don't have the exact stats at my fingertips, but I believe more uninsured got covered either through the expansion of eligibility to age 26 under their parents' insurance and the expanded Medicaid programs than the number of people that went into the public exchange. And I think that also kind of speaks to the purchasing power of where those two groups of people went.
Yeah, that's a good point, Tracy. I mean, it's a little bit misguided to think that health would be something so much served in an individualized market, because the individuals, there's some things in life we do better in groups, and this is one of them. Okay, let's go to the next slide. Now, I mentioned it's cheaper, and then cheaper is very important, but then there's another aspect to the competition that employer coverage brings about, and that's innovation. And sometimes innovation is mundane or not so glamorous, but it's still valuable. And Tracy talked about some of the things like finding specific new coverages, being nimble. That can seem kind of boring. It's not like inventing a brand new vaccine or something like that, although that innovation is important too. And again, when there's consumers well represented the way employer coverage does, that gets the providers on their toes trying to provide a better product to capture these customers. Yeah, let's look at the next slide. And then, and in fact, this goes back to the early days of having health coverage in the workplace, that people spend a lot of time at work and with their fellow employees, and having each other healthy is important. And it could never be a more obvious point now than it is these days when we're involved with infectious diseases, where that's a disease you get from somebody who's near you. And employers have done very well in adapting to that situation. They've gotten real results, I think, in terms of slowing the spread at their workplace and providing new products and adjusting their products, as Tracy said, to that situation. Next slide. And this is yet another aspect of the group purchasing. And one reason we can do things better in the group, you can have specialization. And not specialization in the sense of some faraway bureaucrat specializing and deciding what my family needs. No, this is a specialist who's much closer to home, much closer to your interest. And someone in your company can be well versed on what's going on in the healthcare market and provide recommendations to the employees on what approach they can take to save money, to get better care. And again, this is something that's especially advantageous for people who aren't versed in that. And often they might be less educated employees, lower income employees. This is another benefit they get by being part of a group rather than being all by themselves. Next slide. And then the social benefits, they're both on the tax side by encouraging work, which is overwhelmingly the way incomes and tax revenues are generated in our economy, and also saving on expenditure. If people, the majority of Americans are on these type of plans, if they weren't on these plans, what would be the alternative? Often it would be a government plan. Government have to open its wallet. Uninsured status, which is another thing, which also ends up in the government wallet through uncompensated care. So these are significant benefits that are part of the whole calculus on what's the value of employer coverage. The next slide. And I think this is the last point I should mention today, is that things are changing. Things have changed in the past, and I guarantee you they're changing in the future. And I think Tracy provided in a very empirical way that there's a need to be nimble. Employers were much earlier to telecare than the government was. And that's always going to be the case. The private sector is going to be quicker to the new needs of people than government bureaucracy, faraway legislatures will be. And I think that's what's our next slide? Yeah, if you want to look at the paper, it's not a long paper. We have the link here on the slide. It's being distributed by the National Bureau of Economic Research, nbr.org.
Thank you so much, Casey. You know, I know we have a limited amount of time remaining, but I'm so glad that you focused in on the point about the disproportionate positive value of employer-sponsored coverage to lower paid individuals, because, you know, in so many ways, on so many things in life and in society, you know, lower paid folks get the short end of the stick, but it seems that healthcare coverage from an employer is a shining exception to that general rule, because, you know, the value to that individual is so much greater. And one of the things that always has driven me to distraction is the criticism of the tax expenditure for employer-sponsored coverage, and that, oh, well, the wealthy are getting a better tax benefit from it than lower paid. And you could say that about anything, about home mortgage interest deduction or charitable contributions. You know, somebody who's in a higher tax bracket will always get a bigger sort of tax benefit. But the real issue, I think, I mean, tell me if this is how economists should look at this, is who's getting the greater value? For whom would it be more difficult to get that same level of financial protection were it not for the employer-sponsored coverage? You know, would it be the CEO or would it be the lower wage worker? And I mean, the answer is, I think, is obvious to me. Is that the right way to be looking at this?
Yeah, I think it's always, economics really founded on the idea you want to look at alternatives. If it's not this type of coverage, what is it? And I agree with you that the employer system is something that's been quite beneficial for middle and low income employees. And they're going to be the least interested in moving away from that. They want to stick with it. They're getting the benefits there.
Jason, do we have any other questions in the queue?
One of them touches on what I think is one of the main criticisms of employer-sponsored healthcare, and that is, what are your thoughts on the questions raised about such heavy reliance on employers when people lose jobs like what happened during the pandemic?
Can I just start? I think that one of Casey's points about, many employers continue to provide funding for employees' insurance, even during furloughs or layoffs. Our survey data, and I can pull it for a follow-up after the fact, measured the extent of that, and I think it's pretty impressive when you take a look at that. So I'll just go ahead and kind of reinforce that. Casey, I don't know if you have more that you want to say on that topic.
Yeah, that's something. Again, the talking points tend to be different than the data. That's why I love to see Tracy's data. She's got a gold mine there. But we can see various indicators during the pandemic, very little loss of coverage. Again, it's because of the nimbleness of the market. Employers want to attract and keep good people. And one of the things that the good people and all people say, I would like a little security. When our relationships end, I would like some security and be able to keep my coverage for a period of time until I get on to the next phase in life. And that's a very common compensation arrangement and common for people to take advantage of it.
I guess I would just add that each of the systems that we have in this country, individual coverage, employer-sponsored coverage, governmental programs, they each have their strengths and their weaknesses. One of the things that I think was somewhat reassuring was that the actual number of people who lost coverage overall was substantially less than what had been anticipated given the degree of job loss. Now, if you're one of those people who's in that category, it's a very serious issue. I don't think anybody doubts it, which is why the Alliance to Fight for Healthcare, which is sponsoring today's webinar, worked so hard on COBRA coverage and other measures and the stuff that you were talking about, Tracy, in terms of independent measures that companies took to continue subsidizing coverage or keeping people on the plan, even if they were furloughed, for example. But the Urban Institute and the Commonwealth Fund, showed that notwithstanding some of the job loss, people were either getting it through those means or through another employer-sponsored plan or some other mechanism. So, I think that it would be a real shame to sort of overlook the value added by that employer engagement and the kinds of things that you were outlining, Tracy, by only focusing in on that other issue that was at the heart of the person's question.
And
second question, Jason?
Excuse me. Sort of dovetailing with that question, actually, if we accept that the benefits of ESI should not be disturbed, what do you think is the appropriate safety net for those people who don't qualify for Medicare or Medicaid but can't get employer-sponsored insurance?
So, I think that we have some programs in the market today that perhaps with different incentives, maybe we could address that better. That I'd start there just because I do feel like, Medicare and Medicaid do a very good job in the markets that they serve. We've got the employer market. And so it's kind of a question about the individual market and what else do we need to do to strengthen that. I thought it was interesting. I saw a paper posted today by Jim Capretta at AEI, where he talked about, covering the uninsured. And he had kind of three ideas. One of them, giving employers an option or incentives, if you will, to increase take up of more workers and perhaps those, that are more part-time and perhaps kind of fall through the cracks. But he suggested, leveraging Medicaid as that safety net program. And I know that there are, budgetary constraints with those programs, but, it just seems like maybe we need to align incentives a little bit better so that people don't fall through the cracks.
Casey, do you want to take a swing at that one? I have an opinion about it as well, but you're the featured presenter today.
Well, I'm more empirically based. I mean, different polities have tried different things around this. I think Massachusetts is pretty interesting. Care is supposedly the same as Obamacare, but it wasn't. And one of the things they did that was quite impressive, they got a very big increase in employer coverage, kind of what Tracy was saying to encourage employers to offer it. They didn't really impose big penalties and things like that. They just gave a little nudge, and a lot of employers began to help link their employees up with health coverage, and that the uninsurance rate after Care in Massachusetts was quite low.
I would just answer the question, Jason, by saying, we have this three-part system, right? Individual coverage, individual market, employer sponsored coverage, and government programs, and there's a role for each of those. And I think that one thing that's important to help make the employer system successful is to have a strong individual market for those individuals who, for whatever reason, may not be covered by the employer plan, or work for a very small employer who doesn't offer a plan. And so the two are not necessarily in conflict. I think they really complement one another very well. But I also think it's no coincidence that when people have the choice amongst those three, if they have an employer who offers a plan, they'll almost invariably take that plan because of not only the employer subsidy of the coverage, but also because of all these other factors that Casey and Tracy were talking about in terms of the value added by that coverage and the things that are done to help people have better health.
I have two more questions in the queue. Hopefully we can get them both in. One micro and one macro. Let's start with the micro one first. What is your comment on hospital claims that they have to charge employers higher rates because they say Medicare doesn't pay them enough?
Tracy, that was probably in your wheelhouse.
I was going to defer to the economist. There's a balance. Casey, do you want to answer?
Yeah, I think we both should speak in here, but the supply of healthcare is very important, and often the federal programs can discourage that and encourage consolidation, and then not reimburse, and then that all falls back on us. And so, but I think the root issue is the supply of providers.
It's a very delicate balance, I think, between the commercial payers and the government programs. And, heretofore it has balanced out well, but I will say that employers are keenly aware of any types of shifts or growths in the public program that mean more cost shifting to the private payers. And so I think it's important, that we maintain the balance and perhaps become a bit more sensitized to what is going on with the prices of services. And it's not just hospitals, it's, pharmaceuticals, it's everything in the supply chain. The employer sponsored programs are the end payer. And, I started out by saying the affordability issue is real, and it is real. And, we're all going to probably come to a point where we're going to have to figure out how to work better together. And I think we can do that in a way that supports our current system and continues to encourage and support innovation and the great healthcare system that we have today. But it is a very delicate balance that we have.
All right, I'll let you all wrap up with this $1.5 trillion question. Why haven't employers been able to get their underlying healthcare costs down, and will they ever be able to?
Well, here Tracy and I would be looking at it from different angles, the same thing from different angles. In my perspective, distinguish quantity from price from spending. Cost often refers to how much is spent, and a lot is spent on healthcare, but we're also getting a lot. You look at the progress that's been made in cancer treatment, or how much better our cancer treatments are than European cancer treatments. You look how many more intensive care units we had available per person than Europeans had when this COVID came along. You look how much quicker we get into vaccine than the European Union is getting it. These are all higher quantities and qualities of healthcare that we're getting, and that's a natural progression of technology in the economy. As we get richer, we want healthier. We want to have great grandma and even great great grandma around, and so I think that technological change is the number one driver. Now, adapting to those new circumstances is a challenge, and that's the kind of challenge that Mercer and those companies are dealing with, and thankfully they are helping us deal with it.
I think the real opportunity for all of us is to manage cost by seeking higher value care and not continuing to provide low value care. And that's not something that is going to happen with the flip of a switch or overnight, but you know, we continue to have innovation that helps us all be more efficient. And the more we can move everyone in that direction and kind of leave behind the things that have been replaced, I think the better off we'll be. And I think that the outlook is good. If you look at the cost increase trend on employer-sponsored health plans, you know, going back to 2012, it's hovered around 2 or 3% almost every single year. It's been the lowest it's ever been. And so I do think that we're on to something. Again, I admitted in the beginning the affordability issue is real, but I see a lot of opportunity for us to continue to improve on the current system.
I would answer that question, Jason, by saying the root cause of it is a lack of transparency. I mean, it's a complex issue. There are many elements to it. Probably all of us as consumers, or most of us, are maybe not as judicious with healthcare services as we are with other goods or products. But it strikes me as interesting that healthcare seems to be the one thing that is sort of as commonly accepted by many, and I think employers are the ones who are leading the charge, pushing against this notion, commonly accepted to pay the same amount, if not more, for poor quality as for good quality. We wouldn't tolerate that with just about any other thing that we buy in our lives. And part of that, not to lay the entire blame at the feet of the healthcare providers, but a big part of that is the lack of transparency about what you're getting and the inability to align what you're paying with the quality outcomes. And so I think that's dovetails with what you were saying, Tracy, in terms of like no longer paying for low value care. But we need to know what that is, and we need to sort of see the evidence and the data. And there are just so many obstacles thrown in the ways of employer purchasers, let alone individual purchasers, to really see that kind of and make that kind of comparison and be better consumers. Well, I guess that ends our hour, and I want to thank Tracy and Casey both so much for the work that you've done and for sharing your findings with us. And we look forward to continuing to work with you and bringing forth the important findings that you both make. Have a good afternoon, everyone.
Thank you.